So I'm a person that couldn't keep a job. So why that entitles me to be with you, I don't know. Everyone in this room is 3 times smarter than I am about the details. So I'm going to just try to connect, again, some of the big pieces here, talk about where things are going, but mainly as president of the ATA, I also want to identify some of the big barriers that have to be knocked down if we're going to realize the full potential of what telehealth can do. And I'm going to go really, really, really fast, so listen really, really quick. Okay. First of all, I think the context is clear, and I think you all understand that telehealth is emerging at a time where all of healthcare is evolving. This is a very volatile industry. It is an industry that is filled with challenges, but because we are in telehealth on the cutting edge, it is also a time for opportunities. I think the challenges are serious, and they are and sometimes onerous, but at the end of the day, for bright, smart, innovative people, these challenges are really opportunities. Telehealth has, within this context, emerged into the mainstream at a time of relentless change across the entire spectrum of healthcare. Just think about it for a minute. We are seeing fundamental changes in the scientific foundations of clinical medicine. Diseases that we thought we understood years ago now are understood in a different way because our science is teaching us entirely new things about the elements of clinical medicine. Number 2, the big challenge of translating innovation into, and the key word up there is appropriate, diagnostics and therapeutics. Finding out who the new thing is appropriate for, at what time, and by whom. The epidemiology of chronic illness and the emergence of the importance of promoting health. We're seeing fundamental changes, of course, in the aggregation, and more important than the aggregation, the analysis of big data. We are seeing entire new reorganizations of the healthcare delivery system and how it is financed, and we are seeing a huge amount of change. Don't make me have to go through all these again just because I made the mistake. Oh God, what a dummy. Stop. And now we're into the era of patient centricity, and more important for telehealth, the notion of consumerism in healthcare and in new benefit designs. This is a sense of the landscape that defines all of these new things that are coming forward to us. And I don't know why this is going to be difficult, that ReedTuckson is not good at this anymore.
You're great.
This convergence of so many forces together, whether it is the health IT, EMRs, EHRs, gamification, mHealth, health and wellness apps, social media, sensibles, wearables, telehealth, medical imaging, big data, personal genomics, the quantified self, all of these bubbles are now coming together in new and exciting ways. This is a time of great confusion and of great opportunity. The defining element of telehealth, though, is this relentless innovation in its supporting technologies. The fundamentals that are underneath what we do are evolving as rapidly as our application of these new fundamentals. Think about it as you look at the advances brought by wireless and broadband, combined with innovative software designs, and all that gets us to lead to as we now usher in the Internet of Things. And as the Internet of Things mobilizes and morphs into the Internet of Medical Things. We are seeing cloud computing combined with cloud-based image management and integration. Those are fundamental game changers. We're seeing advances in smartphone technology and miniaturization. We thought the cameras we have now are terrific. Just imagine the resolving power of the cameras in the next generation. The capacity for miniaturization in our smartphones takes what we can do today and puts that on steroids a couple of years from now. And so we have the ubiquitous selfie, of course, translates into having a dermoscope attached to your iPhone. We are seeing this revolution in social networking. I used to be the Commissioner of Public Health for the District of Columbia, as mentioned, and I have a real sense of the importance of geography in terms of how it translates to the etiology of disease and the confounding of the natural history of disease. I understand place. What I wasn't prepared for was to start to learn that our social networks probably have more to do with shaping our behavior than the geographical environment in which we live. So that our social networks become this huge opportunity for good and for bad in shaping what happens in terms of the profile of disease. Moving away from the broadband sensor, the software world, to the sensor technology world, just look at what that's ushered in. I understand you had a dynamic presentation this morning looking to the future of some of what the sensor technologies will give us. I know that I'm excited by the wearables movement for sure, and all that will give, but I'm also excited by what it's doing in terms of the innovation of new medical devices, whether it's glucometers, pulsometers, blood pressure, just the usual scale, all the way through to the new digital Band-Aids, which have the sensors that can read humidity and heat and can scream out to all concerned, excuse me, I'm infected, please pay attention to me. Or the smart Band-Aid that can be the equivalent of a cardiac monitor and a respiratory monitor and can pump out information, hopefully moving people from the highest cost real estate in the universe, called the intensive care unit, to some other environment, and being able to be much more convenient to connect with docs. And then there are, of course, the robotics that are being put into our hospitals, exciting, and then I hope you all are up on the Qualcomm X Prize. This is a hugely fun intervention where Qualcomm is giving $10 million to the teams that can develop the best single standalone product that can diagnose 13 health conditions, capture 5 real-time health vital signs, independent of a health worker. Oh, and by the way, it's got to be a compelling consumer experience. And they've been at this for a couple of years. I've met many of the teams that are working on it. It is a very intensely competitive process, and the winners should be delivered, I think, in the coming year. And so this should be kind of fun. And then there are the advances in gaming technology and also in artificial intelligence. I got to stop doing that. This is fair. But anyway, gaming technologies and artificial intelligence. You know, for years, I was one of the people who would go around to our children and say, you must get a dose of exercise. That's the way we do it, right? You got to get a dose of exercise. And then we found out that giving these kids these games, like Dance Dance Revolution and all those other kinds of things, those movement games, and then we did this study, and I actually have now come and found out with real data that your heart rate goes up just as much playing these games as if you got a dose of exercise. So, you know, our children can just have a little fun every once in a while, and we can turn that into a health experience. So the gamification movement, hugely important. And then finally, there is the transformation in data aggregation and analytics, combined with machine learning, which now propels the analytic movement forward very, very rapidly. So we can now take so much knowledge and extract that knowledge so quickly from our information sources and pump it out in hopefully usable ways. And then lastly, we are going through this innovation in how health services are organized and how they're delivered, whether it is through kiosks, whether it is through new apps that are connecting patients and doctors together, whether it is the teledermatology and the stroke and the ICU, but also in things like being able to respond to individual customer needs, being able to put different pieces of the puzzle together very rapidly in real time. And this becomes critical. All this technological armamentarium has to be made available to meet specific customer needs, and we're getting very good in our industry at being able to do that as well. But here's the point. The point being that innovation for innovation's sake is meaningless. Just because you got some new stuff that seems wonderfully fun, more bells and more whistles than the other guys, if it doesn't lead to better health outcomes, if it doesn't produce value, what's the point? This world has no more tolerance for innovation just for innovation's sake. We are merging in this time of change, and it's all about producing value, quality and cost value. That's where telehealth is emerging. So where is telehealth going? Well, it's completely dependent on whether or not we as an industry, you as users or developers, are able to resolve fundamental social problems that have to be dealt with. You know, number one is escalating costs. If you don't think about costs and what it means, let me just be the bearer of unwelcome news. It is the cost pressure that is dominant in determining what happens from this point forward. There ain't no more money. And if you thought there was, you're nuts. The American people are really becoming pissed off at this slide. We are spending so much more than any other country in the world, and we're getting so less or little for what we are expending. It can't keep going like this anymore. It can't keep going, particularly on the federal side, on public health care expenditures. As you know, about 60% of health care, and headed north of that quickly, is being spent from the public sector. Medicare doesn't have any more money. And I think you've been following the political debate in America, and you understand very well that there's not going to be any tax increase anytime soon to cover any Medicare shortfalls. What's particularly scary is on the Medicaid side. On the Medicaid side, this is what Medicaid looks like. The increase in your Medicaid budget at the state level, but look at K through 12 education. You're not going to get money out of the states anymore. Now, imagine that you are a big major corporation with worldwide competitors. Do you really think any big corporations are going to be spending a lot more? Not really. But the people that really ain't going to spend any more are small business owners who've mortgaged their house 2 and 3 times. They can't take the hit either. So where is the money coming from in healthcare going forward? It's coming from Mrs. Jones on 5th and Vine Street. The gap between what she's paying out of pocket versus what her wages are is huge and growing. That's a very scary place to be, but that's where we are. So when we start thinking about our new innovation, our new bells and whistles, our new things, remember that the person who's taking the biggest hit for that ultimately will be Mrs. Jones on 5th and Vine. We're not spending some faceless corporation's money. We're spending either the taxpayers' money or we're spending Mrs. Jones's money. And that's really why this cost concern is so important, and we need the people to find the solutions. Telehealth is right where it needs to be because we so sincerely believe we're going to do something about that problem. But here's the deal. 10 breakthrough therapies alone will increase government spending by nearly $50 billion over the next decade. It will increase Medicare spending by $31 billion, $15.8 billion for Medicaid, $2 billion in spending from subsidies through exchange plans. These are mainly pharmaceutical stuff. But innovation is costing us more money than it is saving. And this becomes a real challenge going forward. Number 2, where's telehealth going? It's got to solve the problem of suboptimal quality. It is very tragic to realize not only how complex medical care is, but how we have failed as a healthcare world to improve our quality significantly over time. We were told back in 2000 in the To Err Is Human report that we had a real problem. 2000. And it said that we were killing as many people as fit into a modern airplane a day in medical mistakes in hospitals. But a year later, in 2001, we had the Crossing the Quality Chasm report. I'll give you an interesting assignment. If you get a chance after the meeting, go to your Google and put in Crossing the Quality Chasm in your Google, pull it up, and read the executive summary. Read the executive summary about what were the blueprint for change, for addressing suboptimal quality. I want you to read that and then think about where we are today. It'll bring a tear to your eye when you realize that 15 years later, we still are nowhere near the kinds of things that were called for in a very important report. That series was followed up in 2012 with Best Care at Lower Cost that said we are wasting $750 billion in waste. And then last year, improving diagnosis in healthcare. Why are you doing this to me? Oh, I can't win. Okay, so here's what's going to happen. I'm going to teach any of you that have to give talks like on a regular basis, when everything just messes up like this, you just roll with it. You see what I'm saying? And then you beg the audience to just like be in it with you, right? So we're not going to get like freaked out about it. But here's the next one is improving diagnosis in healthcare. And what this basically, and I want you to remember this one because I'm going to come back to this, but improving diagnosis in healthcare is basically saying we are screwing up royally in making accurate diagnoses when it comes to people's primary concerns. And we have a lot of work to do about that. And that's a very good report also, by the way, for those of you who need to read it. Here's the problem. Healthcare is getting more complex, even as we are not using what we have now very well. By the way, healthcare is delivered consistent with the best science about half the time. About half the time. It's a crapshoot. Now, by the way, let me also say this. I love doctors. I'm a doc. I'm the former doc for the AMA. Okay, I ran the professional affairs. That's all of the medicine agenda for the AMA. I like docs. Medicine is hard. It's complicated. I'm not saying these things to be mean to docs. No, docs deserve support and they deserve help in a complex world. We're in the era of genomics. As the number of facts per decision is rising geometrically, as on the right side of that, as our understanding of genetics continues to increase. It is becoming very complicated. The only thing that isn't rising is human cognitive capability. We're just as dumb today as we were before. How are we going to manage through this? And I used to be, again, just to make sure you're going to, even though I'm joking with a lot of this stuff, I'm deadly serious about it. I used to run for 6 years the chairman of the Secretary of Health's Advisory Committee on Genetics. So I love what genetics is bringing. I'm not saying, oh my God, genetics is terrible, we're in trouble. No, I love what genetics is going to do for us. It's terrific. But our ability to use the products and the knowledge of genetics as we go forward is going to be be heavily challenging to us. And already we're not using what we have now very well. Where is telehealth going? We have to deal with the problem of chronic disease. I love this slide. This is the best slide in my whole deck. Watch this. This is so cool. This is really going to knock you out. We have a storm of preventable chronic illness that is washing over a delivery system that we cannot afford. You know how long it takes to do that slide, right? I mean, that's like a lot of work, man. But I just kept thinking about it, and I just had to do it, right? So we are 40th in the world in whether our babies will survive the first year of life. Good news, smoking is down. Bad news, 19.6% of the American people still smoke tobacco, the number one killer in the Western world. Inactivity, 23% of American people get no other exercise than getting up and going to work. None other than get up, go to work. Obesity, 27.6%. Diabetes, up to 9.7%. You all know the numbers. This is what it means. It means that 2/3 of our Medicare beneficiaries have multiple chronic conditions. 1/2, 4 or more than 4 million have at least 6, accounting for that kind of money. The average elderly patient with 5 or more chronic conditions sees 13 doctors, fills 50 prescriptions in a year. But what's really scary about the elderly stuff is that we're getting these diseases earlier and earlier in life, and so we are carrying all of that with us over a very long period of time. It is impossible for this country to afford to medicalize our way out of the preventable chronic illness problem. It is impossible. You can't do it. The economics are not there. And what that means is we are very close to really having conversations in America about rationing care. because we can't possibly afford to treat all these young people with diabetes and obesity and so forth and so on for 50, 60 years, and then also be able to manage them when they're getting older. Where's telehealth going? Depending on our ability to address the fragmented system. When you are a person with multiple chronic illnesses, you need not only an integrated clinical system, but also to integrate the medically necessary social supportive systems. The pieces of that puzzle are broken for 99% of the people in this country. So you've got to figure out the docs, the hospitals, connect them, but you see the refrigerator with wheels on it? Meals on Wheels. Pretty good, isn't it? I did that. Well, you try to figure out how to do Meals on Wheels. It ain't easy, okay? But the point is this: what's breaking the bank of the Medicare budget? Readmissions after 30 days for congestive heart failure for little old ladies. You get discharged to home, you got all the right medicine, nobody's there to take care of you because you're living by yourself, and you don't get to eat, and then you what? You deteriorate, you get back, and guess where you wind up? Back in the hospital for other complications. So food is actually like important. And who's going to connect the pieces of that puzzle together? And how do we connect what happens in the home with what happens out of the hospital and the discharge process and managing all of that? Who brings all these pieces of the puzzle together, and how does it work? It is a deadly serious issue. So within this context, let me just run through 12 kinds of priority areas that at least we're trying to think about, and we offer to you as being important for you to think about if this field is going to maximize its potential and address the fundamental issues that are affecting our nation. Number one, we have got to cultivate and empower physician leadership. Only 50% of family practitioners report using telehealth. They cite training, lack of reimbursement as top barriers. More than half of family physicians identified that they didn't get trained, and they worry about reimbursement as well. Culture change is complex in any industry. But there's no question, and by the way, to the nurses that are here, God love you, you're wonderful and you're terrific. And for the allied health professionals that are here, God love you, you're terrific. But we've got to make sure that the docs in this environment get it. Now, you in the room are early adopters. You're on the end of the bell-shaped curve on the left side. You're the really smart ones, you're terrific. Okay, well, we got to now make some more of you. And we got to move to the middle of that bell-shaped curve as fast as we can. And we've got to get people engaged. Robert Pearl, who runs the Permanente Medical Group, I think got it right when he says that we've got to really have physicians leading it. And overcoming that reluctance will require strong, effective leadership from physician leaders who have, what's the key word? Credibility to influence their peers' decisions. So please, let's go out and find us some more peer leaders and get them empowered and get them out to talk to their colleagues and tell them what can and cannot happen. I was so frustrated by this and so concerned by it that I went out and grabbed the AMA. And we have some very high-level conversations going with the senior-most leadership of the AMA. Now, you'd think the AMA, okay, you know, slow, Neanderthalis, ostrich in the sand. We love the AMA. And they're not being slow or Neanderthal or ostrich-like in this case. They get it, and we're moving with them. So in fact, I'm working on a piece now for one of the major two scientific publications that I'm going to do with their president to write, you know, a review article that will hopefully help the average doc to understand telehealth, understand how they should make decisions with and for their patients. And we're pretty excited about the chance to do this. We're also doing surveys with the AMA to try to survey what's the real thinking of the average doc and what do we have to do to get them on board. So we're excited by it, but again, we have to just embrace physician leadership. Number two, if physicians are going to be able to, man, this is crazy. Anyway, if physicians are going to embrace it, they have to have clinical guidance to know how to use this well. So we have a lot of work to do to provide the clinical guidance for appropriate use of telemedicine. The slide that keeps going away up there was I had a picture of 3 or 4 of the clinical guidance books that the ATA has just published. We're publishing clinical guidelines on a regular basis now, and you're going to see a couple of more coming out in the next few days that we're pretty excited about. But the key that we've had to learn is if you're going to do clinical guidance, you doggone sure need to be in bed with the specialty society for that particular field. If you want to get docs on board, the specialty societies have to become a part of it. And so we are partnering with medical societies as we work on developing this clinical guidance. And so this is important and fundamental. If you do not use the best clinical guidance around managing teledermatology, telestroke, whatever it may be, I urge you, please, you have to get your head in the game around that and use that. And if you find that the clinical guidance that we have available is suboptimal, then you need to let us know so that we can continue to make it better and better, because it has to be refreshed all the time. The point being, we must be consistent with the best science in everything that we do. If we fail to be compliant with best science in implementing our programs, we're not going to capture the value equation. We're not going to produce the quality and the cost effectiveness that are necessary for this field, not only for the field to grow, which is important, but more important, to solve the nation's problems. So the evidence is key. Now, we also want to establish learning laboratories, by the way, as well, which is also important. Number 3. If we're going to have the best science guidelines, you have to start with the best science. Surprised to let you know, telehealth is not a major research priority in America. There aren't a lot of people wondering and walking around going, hey, you know, we need to have more studies in telehealth. So we're going to have to fight for our space, fight for our piece of the turf. So we are supporting AHRQ, the Agency for Healthcare Research and Quality, which is where the health services research comes from. I really want to get all of you to be attentive. One of the things that I do is, again, I get to as I said, I serve on the advisory committee to the head of NIH, Francis Collins. And for years, I have been part of the advocacy group to support the budget for NIH. You would be amazed to see the energy that comes from the basic and clinical research world in support of NIH. They write letters to their congresspeople. They are up all the time, pushing. Every way you can advocate for the NIH budget, they are doing it. And I'm proud to say I'm one of them. Okay, cool. But what's more important today? It is as important to support the health services research as it is to support the basic and clinical research budgets. And AHRQ is that agency. This is our agency. And they have about as much money as the rounding error, on the back of NIH. I mean, it's diddly squat in terms of what they get. But there's almost nobody fighting for AHRQ. So we have to fight for it. And if we fight for their budget, then we have to fight to put telehealth research at the top of the agenda. If you believe that the slides I showed you at the beginning with what the major challenges facing America are, if you think about our relationship to those challenges, why aren't we number one on the nation of studying what we do and getting it right? So we really are supporting that. But I'm also really happy that we are supporting Academy Health, which is the professional home of the health service research community. Margot Edmonds is one of my colleagues. She's here somewhere. I've seen her earlier. Margot, oh, there you are. Margot, she was one of the leaders of Academy Health. They have allowed us to go into their convention and make the pitch, to be able to say, how do we get the young health service researchers to decide to study telehealth? And so we're happy with that. We're also working, Margot and I, on a very big effort to try to take all the literature that we now have that proves or talks about the effectiveness of telehealth and make that more readily available to the nation. And we've got some pretty exciting things that will be happening over the next months. This is important because this is what's in the literature today. In the New England Journal, most studies of telemedicine are methodologically weak before and after studies that rarely examine patient-centered outcomes, instead focusing on feasibility and acceptability to patients. The key words, outcomes. Innovation for innovation's sake is meaningless. Did it lead to better outcomes, the prevention of human misery and suffering? Did it lead to better value? That's, even though your patients like it. Yes, my patients find it is more convenient to use this than it is to get in a car, drive 40 miles over a bumpy rural road to get to a hospital that made me wait for 3 days. No question we do that. We win that argument every day. Now the question is, how do we get the other work done and get that into the literature? And that becomes very important. The existing literature does not settle the issue of whether telemedicine delivers the same outcomes as face-to-face encounters at either the same or lower costs. But here's also one of the things that's important in the innovation world, and we want to make sure that telehealth does not fall into this trap. Much of what's happening in biomedical innovation is happening outside of the peer-reviewed scientific literature. That for some biotechnology innovators, peer-reviewed publications may be perceived as unnecessary. Publication makes knowledge public and communal, whereas the efforts of some companies build on the spirit of private, ultra-competitive entrepreneurship. At a time of increasing recognition of the importance of transparency, this seems paradoxical. So one of the things that we want to make sure is that people that are in our field understand we can't publish in the Journal of Obscure Reports. Several of mine are in there. We've got to publish in the big places, and you can't do stealth research. If you want to be mainstream, you want to be front and center, you got to play the game at the highest level. Number 4, we've got to integrate telehealth into modern accountable delivery systems. And we know the world is moving to these value-based care delivery systems, ACOs, patient-centered medical homes. You understand them. Here's the thing. Only 20% of ACOs are using telemedicine today. It isn't really yet central to patient engagement activities. Nearly half of ACOs reported having difficulties engaging patients. So we've got work to do on this. ACOs are going to move rapidly. You know the reimbursement for healthcare is changing very quickly. On the horizontal axis as we go up, to the right, to the horizontal side, we are being incentivized in the delivery system to move from solo practitioners to more integrated groups. We inevitably will have bigger and bigger institutions that are providing medical care. Poor Dr. Marcus Welby really is dead. And some of you people are young enough that you're looking at me like, who's Marcus Welby? And for those people, they're making the rest of us feel really bad. So on the vertical axis is the movement away from fee-for-service towards bundled payments, ultimately to capitated. And the reason why I have multiple stars all over the map there is because there is no one size that will fit all. There will be multiple combinations of sizes and speed of getting to full capitation depending on market geometry, networks, epidemiology of disease, a whole variety of things. But at the end of the day, the one thing is for sure, fee-for-service as a standalone is dead. And in fact, just not recently, the HHS announced that by 2016, 85% of all reimbursement will be value-based, and by 2018, 90%. This was an important announcement because chief financial officers who have to make decisions about how to expend their capital were basically unwilling to engage yet in this new value-based reimbursement world because they didn't know how long we would stay in this sort of pregnant, not quite delivered zone. And so it took finally, after much begging, HHS finally said, okay, we're going to put a marker down. Anybody that was wondering whether we were going to change now needs to know we're going to change and by when. And right now, when they made this announcement, the people that were in the room were also all the private sector payers. So everybody's in the room together. Everybody gets this. So we're moving to the next level. Ready or not, hospitals face mandatory bundling for joint payments. So now they're going to take the joint payment and say, okay, we're going to put all the pieces together. Everything that has to do with fixing Alan's knee, which is all messed up and mangled, we're going to put all the stuff together, including the physical therapy, the physician services, the admissions, the skilled nursing, all of it together into one payment opportunity. So we at ATA says, okay, we got this. So here's what we're calling for. We're calling for telehealth coverage in bundle payments and CPT codes that will allow us to capture what we do as part of that encounter, allowing the beneficiary to be at any setting, such as their home. ATA also proposed that CMS waive telehealth restrictions on covered providers so that physical and occupational therapists could also be used. So we're going after these things. These are the opportunities that we have to be able to try to make a difference as we take the way the momentum is going and we ride with that momentum going forward. A positive development in this area is that the CMS just announced not too long ago that the next generation ACO model will, in fact, target ACOs who have been successful in population health initiatives, giving them more freedom to use telemedicine platforms to connect with patients outside of the traditional healthcare setting. So this is momentum that we want. This idea of population health is really powerful. My early career was spent in the public health world. When we talk about population health, it almost always has meant what public health does. It's meant big communities of people. Now the world is into populations of health in the clinical side. These are the enrolled population within a clinical entity. And it is saying to the delivery system, you are now accountable for the quality and cost of the enrolled population that you have in your system. That's a different way of thinking than if you were doing fee-for-service. In other words, if you come in and you ask for a new jacket, you make a sleeve. And then you make another sleeve. And then one day you make a back. And you get paid for each little piece. Now, in this environment, you get paid for the coat, all in. I don't care how you get there. You make the left arm first, the right arm first, but we're giving you all in. But now we're looking at this entire population. Well, here's the point. It used to be then that the delivery system only had to worry about the medical care side, the disease that presents, whether you restored health, manage them chronically, or unfortunately they die. Now that you are involved with the outcomes of the whole population, all of a sudden you have a new incentive to go upstream. Let me give you a statistic. 50% of the highest cost claimants last year used less than $5,000 of health care the year before. Let me say it again. 50% of the highest cost claimants use less than $5,000 the year before. The delivery system doesn't now really know or care who's about to get sick. They know who is sick, but they don't worry about who's about to get sick. Now that you get paid for the outcomes of care, you have a strong incentive to know who's about to get sick, the tipping point, and keep them from getting sick. So, knowing the social determinants, the physical environment, the behavioral factors, resilience, spirituality, all of that starts to become the concern of the delivery system. This changes the dynamic, especially if you have telehealth supportive services that will allow you to intervene upstream. Can you intervene upstream, keep people from tipping into being really sick? Now you have a financial incentive to be able to get that work done. And so you're going to have data that's going to help you to start looking at social, environmental, genetic risk, behavioral risk factors, and so forth going forward. That leads me to number 5. Advancing patient engagement for personally appropriate choices. Now that I, as a clinician, need to get and intervene with you upstream and early, I have a lot of data that is going to be available to me to tell me who I need to talk to. I need to talk to Joe. I also know what I need to talk to Joe about. Joe, we got to talk about your diabetes and your exercise and your diet. Okay?
Sir, yes, sir.
But see, you heard the way he responded. What we don't have a good idea of is how to talk to Joe. Now, I didn't know that Joe was a military dude. Now, see, I would have probably talked to Joe, hey, man, how you doing, brother? Good to see you. Okay, you cool? You all right? Okay, look. I might go into my, I don't know if you all noticed, but I'm an African-American male. So, me and Joe, we might have just went on right down, and, hey, dog, how you be, man? We could do the whole thing. I didn't know who Joe was, that Joe's a military dude. So I need to have a different language. I didn't know that my mama, 90 years old, lives on the internet. And if you want to have a conversation with my mama, you need to talk on email. And then because she sends a wider circle of people ever dirtier jokes every day. If I wanted to talk to my son, my 28-year-old knucklehead son, the only way you can talk to him is to text him. The only way. If you've noticed from my presentation, I couldn't possibly live in a text world. I like semicolons, nuance, subtlety. My son's world is very simple. Yes, no, send money. The point being, the patient-physician relationship is a fundamental foundation of Western civilization. It absolutely is. The bad news is we suck at talking to patients. We really aren't very good. Not like Amazon, which really loves me. iTunes, they love me. They know me, and they know everybody like me, and they always want to tell me what all my friends want me to do. And I want to do just what they want to do, because I want to be just like them, because they are really cool people. So we will have new opportunities, conversational interfaces enhanced by advances in voice recognition technology and AI. We will have the opportunity for sensor-enabled medication adherence. Hey, look, dummy Reed, the pollen count is off the charts. Therefore, and they're telling me this, right in my app. Therefore, they want me to use my inhaler in a different way. When I come home at night, they want to tell me, hey, I can tell you're stressed and you're tense, and we're going to do some stuff for you, and we're going to get very involved. We're going to have disease detection on our phone that will, be able to give us the answers. So all this stuff is swirling around the consumer. All these new things. But the issue that then becomes important for us as we try to get creative as innovators is when you got all that stuff together, how does it affect human cognition? Does it make us think in a different way? And so now we start to learn the importance of using our technology combined with health beliefs. How likely is it you will have a health event in the future? Self-efficacy. How confident. I love to tell my patients all the time, here's your prescription. Now you're going to do this, and do this. Okay, goodbye. And the patient's going, man, I don't know how to do any of that. Nobody ever taught me how to self-manage. You tell me I should take my blood pressure. I don't know how to take a blood pressure. Take my weight. When? What time? What kind of scale? People don't actually believe they know what to do. Locus of control. How likely is it your behaviors will affect the outcome? My knucklehead son Lance ran back kickoffs playing college football. Now, you know damn well, trying to talk to him about future health events, he's bulletproof. He's Superman. Me, I got every disease we ever studied in pathology. Different people. Skill building. Maintenance, social networks, tied with financial incentives. All these are tools. If we really care about the health of this country, we have got to get better at understanding people and talking to people and then giving them tools that they can use. The American public is still skeptical about telehealth. They are wary of getting a diagnosis online. They wouldn't be comfortable meeting a doctor for the first time via telemedicine. So the ATA, we're accrediting these programs that deal with consumers. We're saying to consumers, you have rights. You should know whether the program sucks or not. Is it any good or not? And any of you running consumer-oriented programs, you need to get your accreditation. You need to care about accreditation. Just because you're nice people doesn't matter. Just because you're well-intentioned doesn't matter. This is science. This is science. We've got to be good at what we do. So we're really excited about how we're doing on the accreditation side. Number 6, one thing for sure, nobody can hide their performance in today's world. Performance measurement is absolutely key. Whether docs like it or not, whether hospitals like it or not, whether nurses like it or not, the American people are being given a plethora of information that says, do you suck or not? Usually more elegantly presented than I do. The insurance companies are definitely going to evaluate because they can't trust anymore the delivery system writ general. They've got to have high-performing networks, and they're going to, wherever they can, carve out within the network of people in a geography the best performers. They got to do it. And they're going to tie benefit design for the consumer to going to the best providers. So, does telehealth lead to better providers? Does telehealth, if used intelligently, give you better quality and lower costs? If it doesn't, we don't win. We have to make sure that we are winning on that game. But evaluating the performance is key. Aetna, Humana, United Healthcare, supplying healthcare cost data. Attention shoppers, New California website details cost, quality, and medical procedures. So we are collaborating to make better performance measures. We're working with the National Quality Forum, which is the home, the owner of performance measurement. How does telehealth change the way you evaluate quality? Do you need new measures? Do you have to modify? Do we have to ask different questions? These are very important issues because if we don't solve this problem, you don't win in the marketplace. You don't win in the marketplace if we don't solve this. So if you've got ideas on this, we need you. We've just created a American Telemedicine Association's Outcomes Resource Center, another place that will do it. Number 7, we've got to solve the interoperability challenges, and I also got to talk really fast, as if I haven't been already. We live in these silos. The lab, the hospital, the medical group, the employee, the public health, primary care doctor, we live in these silos. Information has got to be brought together that helps all of them to work as one. We have to take the data, analyze it, liquefy it, and then drop it back into the delivery system so that more intelligent care can occur. We have to have actionable intelligence at the medical, clinical level. And that information has to be able to arm deserving physicians with important information. Alerts. This new person with genomic fascinoma is about to come in. What do I need to know about that? It's got to be at the fingertips like that for the delivery system. They've got to know what diagnostic procedures they're ordering that they shouldn't be because it's wasting money. They got to know what facilities they're using that are driving costs. How do I connect to public health? How do I have mobile apps that help to make sure that I'm practicing evidence-based medicine? We've got to have these kinds of tools that will help clinicians to be able to do what they wanted to do when they went into medicine in the first place, and that was to do right. If you're going to have that kind of data, we've got to solve the interoperability problem. We've got the cloud-hosted integration services that are starting now to figure out how do you take the data, put it into the cloud, and then connect it into electronic health records and electronic medical records. We have to have device interoperability so that all these wonderful tools and toys can actually play together nice with the other boys and girls. It makes me nuts to see how hard it is to do this. Why is this so hard today? Why do we have people at the congressional level calling for flexibility and implementation stage 3 EHR? Go back and read the Crossing the Quality Chasm report. 2001, it was screaming out, pay attention to this. And here we are still going, we're not ready, the dog ate my homework. There's going to be all kinds of problems. Oh, we don't want to do. Come on, man. What other industry has fooled around like this? It's just embarrassing. Not to mention killing people. HMS interoperability, another year, another promise. But thankfully, some people are coming together. Healthcare industry giants are now starting to say, okay, let's try to get together and try to push for this. We need you guys. Look, every time there's a delay in interoperability, you know why it is? Because the hospital associations and the medical societies write letters, and then 260 Congress people write a letter to ONC and say, slow down. We don't write letters. We don't get nearly pissed off enough. So I want y'all to get a little more pissed off. Not at me, but We've got to move this stuff forward. So one thing is good is that Karen DeSalvo, who's terrific, who runs the Office of National Coordinator, just announced the other day 3 new challenges grants that are going to basically try to push some of this together faster. Medtronic is not waiting for the government. Medtronic launches smartphone connectivity for CGM's insulin pumps. And so basically, they're now going to connect their glucose monitoring with your smartphone that you can share it with yourself and with your caregiver. So we're starting to see that our industry is actually taking this on together, which is terrific. I worry about this one, though. Like, remember this? I showed you a picture of the blood pressure cuff connected to your iPod, and you send it to the doctor's office. Can you imagine? What are all these systolic 200 over 120? They would drown. There's no doctor's office that can handle all that. So there's going to be some really interesting intermediary opportunities in our space going forward that's going to try to have to take some of this data and make sense out of for busy clinicians. But we can't be looking like air traffic controllers inside of every doctor's office or every hospital. So this is going to be a very interesting challenge. Number 8, you got to pay for it. It's got to be reimbursement. Medicare has really, really been slow. And they've been really problematic. And why are they problematic? Because of a place called the Congressional Budget Office. And why are they so tough? Because they have very rigid analytic things to tell you whether the ROI justifies. Now, every private insurer already got it. Every private insurer is like moving like light speed, but not Medicare. And so we have some real work to do there. But good news is another bill is just being introduced. A bipartisan group of senators led by Brian Schatz from Hawaii has introduced new legislation that will waive restrictions on Medicare telehealth coverage that many considered antiquated or arbitrary. And so we're supporting this with everything that we have. But he says for us what we need to be saying everywhere. In your local newspapers, in your local editorials, or you just write this down and call your congressperson and support the bill. Let's get you. So why is my congressperson not supporting this bill? You can just quote, telehealth is the future of healthcare. It saves money and improves health outcomes. Our bipartisan bill puts us on a path to transform healthcare. I think this is pretty cool. Telehealth parity is now in 27 states and the District of Columbia, which says that you now have to pay for an in-person, for a telehealth visit the same as for an in-person. That's progress, because that was like diddly squat 2 years ago. So we are seeing some movement in that regard. Number 9, the licensure issue. Everybody got sad. Look at you. Everybody just went, oh man, don't talk about that. But I think some other people are going to talk about it later today, so I don't have to hit this too hard. But we wanted reciprocity. We wanted it to be where you got licensed in Wyoming, you were cool with New Hampshire. And that's the way it should work. Only thing, the dirty little secret is, the people that run the medical board in Wyoming don't trust New Hampshire worth a doodly squat. They don't trust each other at all. And they're saying, if I'm going to protect the great citizens of the great state of Wyoming, I'll be damned if I'm trusting those Neanderthals in New Hampshire. We got to have our own. Oh, by the way, I play golf with the docs in Wyoming, and they're really scared that their patients are going to get lost to the docs in New Hampshire. Well, but that really wasn't the reason why. It was mainly that the people in New Hampshire suck. Okay, so there will be no chance we will ever get reciprocity in my lifetime. It ain't going to happen. So now we're fighting for the compact. And the compact is where basically you all sign into a national compact, and for a modest fee, they will process you and do something and you'll get it. So we think the compact is probably going to be the only way we'll get what we want. So we're now fighting for the compact. 26 states have enacted legislation to do that, and we think that might be the good answer. Number 10, we're paying very close attention to the regulation of telehealth technologies. Target is actually getting ready now to launch digital health section of their devices in 500 stores. I mean, digital stuff is going to be right there. And the apps and so forth are there. Top-selling blood pressure app, very inaccurate. Harvard study, diagnostic apps are right half the time. But this is what really kills me. The reporters stood outside of the FDA's office to see who was coming in. And they watched all the people from Silicon Valley came in, like all in a row, like bang, 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 bang. So they stood and they asked them when they came out, hey, what are y'all doing? What do you think? What do you think? And so the guy from Google says, like the leader, health is just so heavily regulated. Well, dude, whether you live or die, whether you kill people, it's a little different than the stuff y'all be playing with. So yeah, it's regulated. What do you think? So here's what they did. Vital signs camera. Amazing innovation. Warning. It's not intended for diagnosis or for clinical measurements. Measurement statistics are provided for entertainment purposes only. Here's what I really like. Medical calculator, absolute neutrophil count, acidosis, acute lung injury, acute tubular necrosis, anion gap, APGAR score, basal metabolic rate. Medical calculators, a set of medical calculators for doctors, nurses, technicians, and students. This happens for entertainment purposes only. See, they think we fooled the FDA. They'll never look at us because it's just slid right under. No, it ain't going to work. But here's the thing. We can't have regulations so heavy that it stifles innovation to come forward because then they're going to get caught in a bureaucratic nightmare and never get out. We've got to really attend to this, folks. And this is something that's going to be worthy of all of our attention. One good thing is, at least, that they are using now a new act on medical device innovation, which aims to help now those that are creating these devices and apps to better understand when their product or marketing claims crosses over into regulated medical territory. So they're trying to give them that. But we don't want them to be scared of being in regulated medical territory. We want some new tools that we can actually use in the regulated medical world. So we've got to be very careful how this goes forward. I won't have time to do that. I'll move. But what is happening also is hospitals are starting now to become app curators. The hospitals are starting to say, you know what, patients, here's like 50 apps, and we've looked at them, and we recommend these 3, 4, 5, whatever. We're putting our seal of approval on it that you can have confidence in this, and we can work with you on this. I think this is a very important trend. Number 11 out of 12 is expanding access to broadband for all. If this field is going to move forward, you got to be connected. Simple. It is infuriating to realize how many rural Americans and inner city Americans do not have access to broadband today. We take it for granted where we live, but there's millions of Americans who are not having access. And so we were happy that the other day, see, they wouldn't let me use my computer. And they gave me this other thing, and they gave me the thing and the clicker, and the dog ate my homework, and the reason why we don't have an interoperable medical records is look at me making the same old excuses. I have no shame. And then the guys in the back, who are the technicians who work so hard, are like really angry at me, and they're like going to pull the plug out of my presentation because I'm making it seem like it's their fault, and it isn't. We got to deliver. Here's the good news, is that the FCC in a 3-2 vote, 3-2 vote, who were the two? Expansion of Lifeline, a federal low-income phone subsidy program that covers internet service. Now, we really don't want them poor people to have access to stuff that may save their lives. I'm voting against it. And finally, we have to be attentive to research. Stop. I talked about health services research, but let me remind you about clinical research and how important it is. If you think about how much the drug prices are going up, part of that is not because people like Scieli, who is the worst dirtbag in the universe, that guy that, you know the guy. But can I get sued for that? I actually didn't pronounce his name right. Skelly. I'm talking about a guy named Skelly, whoever that is. But you know who it is. It's also because the economics of trying to do clinical research are very expensive. Well, geez, first of all, it's hard to enroll patients in clinical trials. Our mHealth apps, all the social connectivity we have, we ought to be really good at getting people into clinical trials. And then the cost of doing the clinical, we got all those sensors and the devices and the wearables and the blah, blah, blah. We should be very good at bringing down the economics of all of this. So the other day, Francis Collins comes out at NIH to basically say that for the Precision Medicine Initiative, which you've all heard about, that they're going to test and maintain connected sensor technologies as a part of the initiative. They have to test it because you got to know whether or not the sensor actually actually works in real time, and does it produce really reproducible information. But then, and finally what he's saying is that this team will explore optimal approaches and systems for engaging, enrolling, and retaining participants in this cohort, and telehealth is going to be a big part of it. So I want you all to think about research as fundamental to the future of telemedicine. That puts us center core with some of the most exciting priorities in the nation. Well, I have had a fun time trying to run through a lot of things with you. The conclusion and the summary, 3 minutes over time, and I hope that doesn't mean you lose 3 minutes in your break, is this is our moment. What we do is vital to the national interest. That's good news in the sense of why we are important. The bad news is, since we are so vital, there's more pressure than ever on us to get it right. We're no longer experiments. We're no longer a club. We're no longer just well-meaning innovators. We are front and center in front of the nation's most important challenges. We have got to get this thing right. There are too many people depending on us. I love being in your company because you all are the people not only who are going to teach us from practical experience how to get it right, you're the ones that are going to tell us from practical experience how we need to remodify, change, or enhance what we're doing. And you are the people that are going to help us develop the evidence basis that will not only prove ROI, but it'll also be the ones that will create the evidence basis that will allow us to develop better clinical guidance and better performance measures so that we ultimately have a learning laboratory of telehealth integrated into the momentum of the fundamentals of how healthcare is being shaped and redesigned. Thank you for everything that you do.